Good morning, everyone. Welcome to session A3, Mitigating and Aiding Vulnerable Populations, presented by, presented by Bright Shores Health System. My name is Ken Zolatar, and I am joined by my colleague Bethany Parkinson, and we will be your facilitators for the session. I have some quick housekeeping notes, and then we'll introduce our speakers. I'd like to draw your attention to the bottom of their screen. You can use the chat feature to submit questions.
I see someone speaking, but I cannot hear anything. Am I alone?
Can everyone hear me? If you can write in the chat a little yes, thumbs up. Okay, great. So sorry, let me get back. Sorry about that. So some quick housekeeping notes, and I'll introduce our speakers. I'd like to draw your attention to the bottom of your screen. You can use the chat feature to submit questions. Please type question in all caps so that we can flag that for our speakers at the end. It'll make us easier to find. The speakers will take questions at the end of their presentation, and we'll answer as many questions as we can. Please ensure your microphone is on mute until the Q&A portion of the session. Please note that the session is being recorded and will be uploaded to the conference website for future viewing by those who have registered for the conference. You'll have access to the platform for 90 days following the conference. Also, we'll put in the chat, we kindly ask that you complete a short evaluation at the end of this session. Your feedback is appreciated and will be used to inform future events such as this conference. Another space to find that evaluation is on the conference platform. If you click more on this session, there's a section to fill out your feedback. Lastly, we ask that you engage with each other thoughtfully, respectfully, and consider the impact of your words and interactions. As facilitators, we will not tolerate abusive or inappropriate behavior, and will ensure that anyone who engages in such behavior is removed from this session. All that being said, I would now like to introduce our presenters, Heather Prescott and Robin Nosilla from Bright Shores Health System. Heather and Robin, over to you.
Thank you, Ken. Hi, everybody. Thank you so much for attending and having us speak today. Heather and I are very honored to talk about this amazing program. So we are here to talk about Bright Shores Outreach Service, which we identify as SOS. And we're talking about mitigating and aiding the vulnerable populations. So my name is Robin Nosilla. I'm a nurse practitioner within the mental health and addiction for Bright Shores. And my co-presenter.
Hi there, I'm Heather Prescott. I'm a nurse practitioner. I work for Bright Shores. I'm seconded to the Grey County Paramedic Services to provide the mobile outreach service. And Teresa's not with us here today. I wanted to share a land acknowledgement before we begin. We acknowledge that we are situated on the traditional territory of the Nawash and Saugeen Nations, a place that has long served as a site of meeting and exchange among many First Nations, including the Iroquois Confederacy, Huron-Wendat, Abenaki, and the Anishinaabe. We recognize and respect the Anishinaabe as the traditional custodians of the lands and water. We are committed to supporting the Anishinaabe and the Haudenosaunee peoples, among other First Nations, Inuit, Métis, and Indigenous peoples. We recognize the impact of colonialism on the First Nation people daily in our work. We also acknowledge the people of color whose ancestors came to this country against their will. We hope to make time, space, and resources available for truth and reconciliation.
Thank you. So of course, when we present, we have to talk about disclosure of financial support. I have received speakers honorarium from Indigenous. I am a presenter for Master Clinician across Canada, and as well have consulted for the Medify group.
I don't have any financial sponsors, no research grants or honorary at this time, no consulting fees, and I'll just skip Teresa's here.
All right, so today we wanted to talk about what makes SOS so amazing and why our project has been so successful and where we're going with it. So we're going to look at identifying barriers to accessing addiction services in the Grey Bruce area. We're going to talk about exploring the development and evaluation of the SOS mobile team, so how it came to fruition and how we have extended it as long as we have. And we are looking at distinguishing between the SOS mobile team as well as the other existing models of care. So how do we collaborate with our model as well as everything else that's going on within our community for addictions and mental health services? So we want to talk a little bit about how SOS came about. So SOS initially was born out of the COVID-19 outbreak response. So initially we had a rooming house of over 40 individuals that unfortunately developed COVID-19, and we had to isolate the entire premises of the building, which as a rooming house had significant barriers to care, including mental health and addiction. And so in 2021, Grey County came together with multiple partners, and during the outbreak highlighted the need to address health equality and health outcome gaps that had been seen within these individuals and the groups in the building. So as you know, when you respond to a crisis and you support those individuals during crisis, and you see benefits, you can't just pull back. And that's what we were seeing, is that once the crisis was over, these individuals really thrived and were doing well during the entire time that we were there. I believe over 4 weeks, we had no overdoses whatsoever. And prior to that, they were responding to overdoses on a regular in that building. So we, with dedicated workers and volunteers, came up to understanding and building rapport and trust with these individuals, and creating a hub, if you would, for vulnerable individuals to feel heard and autonomous and have choice within their recovery and within their primary care. So in June of 2021 is when we responded to the outbreak, again, impacting 40 plus individuals with extremely complex needs. During the summer, I'm pretty sure it was a record summer. I think I lost weight just by being in those hazmat suits. It was hot. This was a building, no air conditioning. You throw in 30 plus degree weather, you throw in hazmat suits. It was not the easiest work environment for those people that were there, and for the individuals living there. Again, when you can't leave and you're in that building, of course, they were addressed with how do you air conditioning that without the air quality of COVID, and how do you provide water and provide cooling stations, etc. And we moved to the fall of 2021. Where again, we see all these benefits of having a mobile unit and needing ongoing support. So the SOS markets were created, and that is where they are fixed sites in 2 locations, initially started in Hanover, in Grey County, where the initial COVID outbreak was, out of a church. And individuals would come to that market where they would access multiple services, and what would that look like when we then extend that market. So it got extended to the Owen Sound site, and in January 2021 SOS mobile team was created. So it was a 12-week initial pilot project that was established from the mobile outreach, and it ideally came from meeting clients where they were at. And then in June of 2023, the Ontario Health Team West came about some funding, which was great, which funded full-time staff of 5, including a nurse practitioner, an EMS in terms of a community care paramedic, a mental health counselor ×2, and a social navigator. So this is really the essence of the SOS team, and we'll talk a little bit about why it is working so well, having that collaboration between professions. So
Sorry.
our community, oh, sorry, go ahead, Heather.
So our team can't reinforce enough the importance of our interagency collaboration. Without our partners in both health and non-health agencies, our project wouldn't have the financial or the human resources to meet the complex needs of those people that we serve. So here's just a small list of some of the partners that we work with very closely. There is up to 25. Some of them are health, some are social, some are volunteer-based, lots are non-for-profit. You'll see our municipalities and our counties there as well. So after the initial outbreak that we had in Hanover, the SOS, I feel like I am off my page. Sorry. I flipped one the wrong way. Had to happen. Sorry about that. So after the initial COVID-19 outbreak, a debrief was completed, and it provided an opportunity for our partners and teams to identify the barriers to access and start to begin to measure and monitor the impact of health quality and equity in this marginalized population. So what we identified is that this group had very little or no income source, very low employment, a variety of individuals on Ontario Works or on ODSP, many without either. The community was transient with no fixed address. Sometimes in this rooming house, there'd be 4 to 6 individuals living rough or couch surfing, even floor surfing in some spaces into one unit. These individuals lacked identification and were unable to access things like emergency shelter, which in our region is through a motel program, access controlled substances like OAT because they did not have a health card or identification, or you could even get a bank account without ID. There's a high prevalence of mental health, substance use disorders, including opiate, methamphetamine, cannabis, tobacco, and alcohol-related disorders. There was a high prevalence of domestic violence, abusive relationships, and survival sex work. This group was detached from the health system with minimal access to health and social supports due to their equity, situational, and personal challenges. Lots of barriers. So the debrief results were completed by our regional public health unit. They continue to be our evaluation partner in this program. They identified some successes, which included a very rapid response between organizations with a patient-centered approach. They identified there was a reduced visits to the emergency room. As Robin said, there was no overdoses and no deaths occurred due to COVID or other health issues. There was minimal police interaction, although they were always available. And there was an improved uptake of addiction treatment options. So recommendations that were made included establishing a community partnership with a mobile outreach component. Robin had mentioned that we'd had these fixed sites using a church initially, but this provided us an opportunity to go where the people were or people who could not access these traditional sites. It provided us a coordinated community care to help reach individuals who would not otherwise access services. So sometimes this meant attending directly to encampments, attending directly to traditionally known flop houses, for example. Other recommendations included addressing health equity, situational and personal challenges to accessing these supports. And they identified 2 fixed locations that they suggested we set up in our counties, which included the municipalities of Owen Sound and Hanover. And finally, they recommended that we evolve and expand our services countywide when possible. The organization of the project, a logic model was developed together with public health to show the relationship between our resources, the activities that would be completed, and the intended results. This was used as the foundation for developing an evaluation framework and key indicators for monitoring implementation and identifying areas for improvement. A health equity impact assessment was completed and used to prioritize opportunities for improved health equity approach, including the collection of more detailed demographic data to better understand and stratify the clients we were serving based on equity indicators and understand our impacts. This is a very high level image here of our SOS mobile framework. The direct inputs here include their health human resources, a paramedic, a nurse practitioner, mental health counselors, and a social navigator. Our collaborative partners, as I mentioned before, in health and community organizations. And then our intended outcomes, the right type of care, the right place, the right time, including medical care, addictions care, crisis management, comprehensive mental health care, COVID-19 response, wraparound social care, and supportive system navigation. Now, the project governance, as you can imagine, is challenging with 25 stakeholders and agencies involved. The initiative is a collaborative project, and there's a multidisciplinary leadership with decisions made through what's called consensus building. The SOS initiative is divided into 2 streams, SOS Fixed and SOS Mobile. The fixed and mobile clinics are supported by an operations working group and a planning and evaluations group. The diagram here demonstrates the collective impact approach. The SOS Collaborative is comprised of all stakeholders and partnerships. And our mobile team, the nurse practitioner, myself often, functions as the clinical team lead, with all members having a joint role in developing patient-centered plans of care, and the leadership team acting as our backbone and as our funders and for advocacy. Naturally, there's overlap in our roles and mitigated with good communication and careful documentation. So an example of my role or the NP role versus the counselors, what the paramedic may do, and our social navigator. Off to you, Robin.
Thank you. So this
I have this one. Sorry.
You do, that's okay.
I was like, oh, I got all the pictures. So our evaluation framework, finally, looking at our community focus as a primary marker, our community engagement, views and involvement with the community who utilize our services. Resources and services include fostering our community engagement, our collaboration and trust, taking note of the number and resources used and services delivered by SOS, our quality and performance, integration and responsiveness, integration of SOS into the healthcare system and community service system, and capacity to continually transform to the response of evolving needs, issues, and evidence. And then finally, determinants of health and equity. Public health often takes the lead here with our health determinants and status, and identifying the trends in disease mortality and morbidity and health behaviors. Sorry about that, Robin.
That's okay. So this is a really busy slide. So I'm just going to kind of point out the main points of this slide, that this is our logic model. The inputs, strategies, activities, outputs, short and long-term outcomes to support the goal of, and the goal of meeting people where they are to provide person-centered health and wraparound mobile response to improve the health outcomes and the health equity in those individuals who experience barriers to access to health and social services. And I'm sure everybody we work with could fall under this logic model, which is why it's working so well. Next slide. Perfect. So when we're talking about the SOS team, we're talking about the mobile team specifically. And with that, we're talking about SOS Mobile being staffed by 5 individuals Monday to Thursday. And that's an 8:30 to 6:30 schedule. Beyond the fixed market clinics, the team attends pop-up clinics on a scheduled drop-in centers, town libraries, and local churches, supportive of harm reduction practices, often together with partner agencies. So we've talked a little bit about that. The team travels up to 100-kilometer radius to meet the rural demands of our community without reliable public transportation. So if those aren't used to Grey Bruce area, picture the outline of Prince Edward Island. That's basically the location diameter, if you would, or travel distance that we would for our Grey Bruce area. We also deliver street outreach to local encampments, flop houses and rooming houses, where we need, where we're needed and invited into. And I think that's a big piece, is that we're invited in there. We've built trust, and specifically Heather and her team has built that trust, and it's taken a long time to do so. We provide home detox services and same-day addiction medication starts, especially for those individuals coming from incarceration or into the women's shelter from out of area without a prescription to continue treatment and with very low tolerance. So really important, you know, to remove barriers and remove walls for treatment. Grey County Paramedic Services provides a designated specially trained paramedic, so a community care paramedic, means of transportation, so our truck or ambulance, staff room and medical supplies that is required to provide primary care assessment, and street medicine services such as buprenorphine, naloxone sublingual, otherwise known as Suboxone, antibiotics, wound care, for example. We also do Sublocade, which is a long-acting injection of Suboxone. They also do methadone and Orcadian, depending on their choice. Grey County is the fund holder of the program for Ontario West Health West. Grey Bruce Health Services, which is now Bright Shores. So you'll see where we say Bright Shores Health System, we've just undergone a new name for our organization. It provides a mental health and addiction NP, which would be Heather in most cases, and the supplies necessary to provide the mobile RAM services, so such as the medication, again, that we talked about, and the urine drug screening kits. CMHA Grey Bruce provides 2 designated mental health and addiction counselors with harm reduction training. United Way Grey Bruce provides a designated social navigator with additional qualifications and life skills training in the ID clinic. They also provide the basic needs supplies that are all acquired through fundraising. So items such as tents, sleeping bags, tarps, toilet paper, hygiene products, period products, and thousands of socks. I've seen them, thousands of socks. And then Public Health Grey Bruce provides the harm reduction supplies. So we're talking anything from shorts and longs, meth or crack pipes, cocaine kits, as well as naloxone kits, condoms, and point of care testing for hepatitis C. They also complete the evaluation of the program, which is really important for us to know where we need to improve or change or get more funding. So in scope, so when we talk about the SOS mobile team, we talk about the demand for primary care services in our region being very high. And I'm sure everybody has the same demand because of the lack of primary care providers, long emergency department wait times, and maybe for those areas closures, very limited walk-in services. So we have no walk-in services in our area in Grey Bruce. Grey County has also experienced an influx of retirees and a population boom during COVID. So a lot of people from the city came our way because of the great space that we have between neighbors. It is beyond the capacity of the SOS mobile team to do primary health care needs of all of the residents that are in need. And so they specifically aim to work with those most marginalized, including unable to access primary care due to stigma and or discrimination, whether that's because of race, gender, mental health, addiction, stigma, mental health and or substance use, unsheltered or precariously housed, struggling with social determinants of health, Indigenous, LGBTQ2+, women leaving domestic violence, and sex workers. And they also prioritize those needing brief case management, system navigation, and then ideally referral back to existing health and social services. So these are just some of our partnering. So we recognize the impact of colonialism on our First Nations people daily through our work. We have 2 Indigenous reserves that we work very closely with. We also acknowledge the people of color whose ancestors came to this country against their will, and we hope to make time, space, and resources available for truth and reconciliation. So when we talk about short-term aims, I think, you know, we strive for developing and a provision of mobile outreach services, increasing awareness of and referral to health and social services. And we know that, you know, across the board, that can be very difficult. We want to increase awareness of harm reduction practices. So understanding that recovery is not just abstinence-based, you know, how do you use safely and reach your goals. Effective day-to-day service delivery and management of operations. Clients satisfied with the model of service and direct services they receive. So it's not about us without us. So our clients have to be happy about what we're doing, or there's no point. And trusting and positive interactions between clients and service providers. So again, reiterating that Heather and her team really do build that relationship back up with people who do not feel the healthcare system has served them very well. Our long-term aims or outcomes that we're looking for is increased integration of services across the healthcare system through interagency collaboration. I think this is an excellent model of showing how interagencies can collaborate and create a team and a team of dynamics that serves our population. Decreased need for utilization of urgent and acute care services and cost savings to the health and social system. So, you know, preventing those emerge department walk-ins or left without being seen that really do add up. Improve health and social outcomes. So looking at drug use behaviors, access to housing, employment, and income. So we have amazing stories that we'll be able to tell at the end of people who have been very successful utilizing SOS services. Reduce health inequalities, maintain support of mobile outreach services and sustain models. So obviously HR and finances, that's a big part of achieving this goal, is continuing to do the work if we're funded. So when we talk about initial evaluation, I want to talk a little bit and have you guys understand SOS. So we, Heather, did you want to go back to the video? Oh, you're on mute. Sorry, guys, we're just having some technical difficulties here. Are you gonna do the, there you go. All right. So I don't know, Heather, I can't hear that.
That is strange. It worked fine before.
As some folks might know, the opioid crisis really hit a peak during the COVID outbreak. In some communities, overdose deaths went up to 60%. The SOS team is a multidisciplinary, multi-agency team aimed to provide health, social, and wraparound services to folks in our community who might not otherwise have access or the ability to reach our traditional services. One of the things that makes our program really unique and points to the success is how we've been able to collaborate with so many agencies in our communities and build on their successes and resources. In the first 6 months of the initial pilot project of SOS, there was over 300 primary care visits, over 300 mental health harm reduction visits, over 1,200 unique clients, and over 3,000 units of basic care needs delivered to patients. We have a phone that we keep with us that we access phone, messages, and text. We travel where we're needed all over Grey Bruce. We bring with us whom is most appropriate, the best resources available. Very frequently, we're meeting folks in the streets, in their apartments, sometimes at other agencies, just trying to make folks feel comfortable in whatever environment works for them. Most notably, I'd say our patient outcomes are significantly improved. This is a really unique program. We're really truly meeting folks where they're at, providing them with choice and safety and trust, and also improving patient satisfaction.
I always say, like, you do not realize the power of just talking to somebody, just getting what is in your head out.
All right, so when Heather puts that slide back up, so that video was shot based on SOS receiving a quality award for our area. And so really nice to have a video to show and acknowledge the work and what the team does. So the initial evaluation. So initially, an activity tracker was used to record activities and referrals taking place at SOS Fix markets. And then electronic survey database was developed to comprehensively gather the SOS activities completed by the program partners for both the Fix and the mobile sites. And then the results are inclusive of services provided based on February 22 and March 2023. So in a snapshot, there was a total of 518 interactions between that time, 247 new clients, and 271 returning clients, which I think is a really important stat when we're talking about our population, that they came back. We have almost 1,200 services provided and a total of 176 referrals made to alternative community partners. Number of harm reduction supplies distributed were 639. Number of primary care services around 157. Number of mental health and addiction brief counseling sessions were 260. COVID vaccines 11, and units of basic items distributed were 226. So when we talk about the initial program impact, I do want to talk about a little, because we're talking about justice. So 300 visits from West Grey pre-SOS. So West Grey is our police in Grey County, basically. They had 300 visits prior to SOS. Those visits by police officers were reduced by 75% since SOS was implemented in Grey. It seemed high, but those are the stats. SOS and mental health drop-in clinics have increased in that area at the same time, have impacted as well since SOS. The 30-day readmits to emergency from the emergency department to mental health are down from 26.5 to 19.3%. The 30-day readmits from emergency department for substance use from 30.6 down to 27.1. The referrals from rural hospitals to withdrawal management increased from nothing to 2.7% since SOS has been implemented. And referrals from the Owen Sound Hospital to withdrawal management, which is our local detox, increased from 12.7% to 18.2% since SOS has been implemented. And on top of that, we have had improved access and decreased barriers to health and social services. We've developed trust through safe, supportive, judgment-free services, consistent access to multiple supports in one place, no wrong door approach, timely access to basic needs and medical supports, and improved care and health outcomes, which obviously you can see from those stats just from Grey region, let alone any other police station. We also have OPP, Saugeen Shores, Hanover Police Department, so significant. Benefits of service provider collaboration. So improved knowledge and understanding of services available. New and strengthened partnership with shared goals. So we have a strong partnership with CMHA as well as Grey County paramedics, as well as all of the other services that are in partnership with us. We have increased ability to provide continuity of care. So again, that client coming back and building that rapport. Stronger working relationship within our organizations, no silos, and improved understanding of the barriers that people face. So it is our patients come first, our people come first, our clients come first.
Now, public health provides us with a formal evaluation. This is available in real time because we do submit our statistics for tracking via mobile device, and it gives us very accurate real-time data. The utilization of this electronic survey database permits us a much greater detailed demographic data and a better way to stratify indicators and understand the program's impact. A few of these will be shared on the following slides. This is an image of our interactions over month to month, looking at an entire year. You can see in blue our new individuals versus our returning individuals. In February of 2022, when we began tracking, you'll notice there in May of 2022, that rooming house that brought all of our agencies together with that COVID outbreak burnt down. And there was suddenly 40 plus individuals who had no shelter, no ID, no health care, and required quite another wraparound supports. You see, we've been steady all this time with some blips here and there, sometimes seasonally. The next slide you see here is the type of services that are being provided, whether it's addictions medicine, counseling and case management, education, primary care, or other types of supports. You can see month to month again, a big change in frequency happening in May, and then leveling out but never really coming down. The next slide shows drug of choice. Currently, we are tracking those who self-disclose alcohol use, cocaine, crack, fentanyl, heroin, marijuana, methamphetamines, other opiates, and speed. And you can see in our particular region, the self-disclosed drug of choice is methamphetamine, followed by marijuana. Fentanyl is very, very close. The next slide shows the type of basic needs that are provided. Again, these have to be fundraised by some of our other agencies. These are not sort of built into our funding model. Things like clothing, food and drink, and personal items. Interesting to see that the age range primarily for our group that are accessing these types of services are between 30 and 39. And on the next slide, looking at the frequency at which people were accessing services. So I'm interesting looking at Christmas of last year, quite low at that time. Not sure exactly why. Sometimes even a simple lack of reporting can create a blip like that. Robin mentioned the number of referrals being made, again, the no wrong door approach, and our efforts to eliminate the bottleneck that can occur when we refer to a single agency, say CMHA in our community, who certainly wouldn't be able to absorb 150 new addictions referrals. Our team does do brief case management and brief counseling for individuals kind of waiting on these wait lists when they've been referred. And the next shows just a variety in our screening tool, our data collection tool, the number of areas that you can choose to select depending on the type of services being provided or the referrals being provided. Very frequently, we're referring to our own addiction services. That would be our detox or our RAM. Our Bright Shores case management team, which could include ACT, aftercare, etc. Peer support is offered by CMHA. We do have an increasing number of programs within Bright Shores offering peer support also. A residential treatment center, telemedicine is used for urgent psychiatry visits. Our community paramedics sometimes follow our more stable individuals who may have chronic health issues that do need to be monitored, such as hypertension or diabetes. Public health, CMHA housing. Some individuals are not able to be treated thoroughly and are referred to the ER. This happens very infrequently, and we have very positive experiences with our ER. In the example that Robin provided from Hanover, the emergency room there was very good to us to provide all the supplies for us to offer support dressings for the burns that occurred to help avoid individuals going to the ER unnecessarily. I mean, our funder generally is always the OHT West in some regard. So it's really just same money coming from a different place. And with that many individuals feeling the same way, we're just meeting the need. And it's been a very, very great experience for many of our different hospitals coming together to work towards the same goal. When you look at our medical interventions that might be provided by the nurse practitioner on the team, addictions medicine, opiate agonist therapy, ordering of lab work, our community paramedic can draw lab work at the scene. Less frequently used now, but our COVID-19 assessment, testing, and treatment. Infectious disease blood work is completed frequently for hepatitis specifically. We work very closely with a hepatologist in London. We do a lot of STI, UTI management, and frequently do urine drug testing, even for those who aren't accessing addictions medications. Sometimes they just want to know. It's a great teaching opportunity. And we're actively looking to expand our services to include drug testing. We do not have a supervised consumption site in our area. And finally, some of the other site services that might be provided. You can see lots of primary health care options here: transportation, safer supply distribution, naloxone education, brief counseling, case management, or completion of games. Just a number of the services that we provide. So looking at our overdose data in the last number of years, public health was able to suggest to us that this significant decrease, a 60% decrease in overdose deaths in our region, specifically during the time of COVID, was quite rare, and attributed it to the SOS contact. So we give out at least 50 naloxone kits a week. We know they're not lost, they get used in the community. A lot of these do not get called into 911, again, out of fear or stigma, but we know they're used, and we've had very, very few overdose deaths or opiate poisoning deaths in our community since SOS. And as Robin mentioned, in many of our rural and our regional hospitals, there's been a decline in mental health visits to the emergency room and repeat visits to the emergency room. This is my favorite part, is the stories of success. So our team has been very fortunate to encounter individuals who have kept coming back to us on and off, given the chronicity of substance use disorder in various stages of wellness. You can see here an individual male who has been granted visits with his beautiful young daughter. His partner was pregnant during the COVID outbreak and received all of her prenatal care by the SOS team until the very end. She, very, very healthy little girl. You can see at the very top, we have some sacred medicine that is offered at our markets by some of our Indigenous partners. We are very fortunate to have been invited into the space on multiple occasions to work hand in hand and offer medical services to a community that has for a very, very long time not wanted us there. So we are very grateful for that opportunity and continue to learn and take their lead. And on the top right here, you'll see some of our outreach housing workers. Our local fire department took us out on the ATVs. We have a long, long rail trail, a lot of communities do, and individuals who are stigmatized or unable to access other housing options may choose to live in various states. Some are in tents, some have actually built little compounds where they're allowed us to come out. We've been able to provide medical care and help connect them to more traditional services like our housing workers. So we've dropped off water and food items. We've dropped off period products and hygiene products, and also sharps and harm reduction supplies via the ATVs in the past. And then the very bottom here, you can see two females who are getting their first Sublocade injections together. This is not at a RAM clinic. This is in our drop-in center. So we don't have a shelter in Grey Bruce, but this is our drop-in center that has daytime hours. They've now extended overnight, but it is not a sleeping shelter. So they are very proud to take this big step together. Just some examples of some really good things that we've done. And on this slide, I'm just gonna move my pictures here. I'm just going to read this. Thank you so much. I appreciate it. You have no idea how much my life has been affected by all of this. You literally saved my life. I always like to follow this, that no, we didn't. You did the work. I'm glad we are here to support individuals through the change process, but they do the work. I wish there was more things like this in other communities. I think it's an amazing program, and I hope it continues. 100% saved my life. I see radical differences in the way you treat us like humans instead of low-life junkies. I almost cry when I read that one. You guys are really superheroes. This little grassroots invention should be practiced everywhere. And this is sort of our open invitation to you. You know, this didn't come from leadership. This came from folks who really cared and were passionate and made it come to life. Organizations who maybe worked in silos before, choosing to work together and make it work to help serve the communities and vulnerable folks who wouldn't normally be served. So challenges remain, can't lie. We are very lucky to have received some longer term Ontario Health West funding, but we do continue to struggle with stigma and discrimination. Never anticipated my role as an NP to be so heavily based on advocating for this client group. We continue to have a lack of supportive transitional housing. I don't know how many folks are here are from rural areas, but to not have a shelter is incredibly challenging. To try to provide a follow-up mechanism to see people again when they are forced to be so transient. The lack of financial stability and long-term funding is a challenge for every program. I'm glad we can say we've moved from the pilot phase to a program phase, but we're currently working with like a 12-month funding model. I'm sure we can all agree that we're working within a time where there's a toxic and unregulated drug supply. This is not the drugs of the 60s. Things are far more toxic, and we are seeing overdoses at a rate that we've never seen before. Lack of drug testing and no supervised consumption site and no shelter in our area. And of course, a human resource difficulties, as so many others are finding, getting the right people, keeping the right people, and trying to house the individuals who are coming from away is very challenging. There's often times where we could get more counselors or could get more supports and nurses coming to our communities, but there's just not enough affordable housing for them to stay. And finally, my last gripe is that our program is funded for 4 days, and we know that these individuals have needs that aren't being met 7 days a week, and we really hope to grow our program to 7 days soon. We love people to call, we love people to visit, we like to do ride-alongs, take people out in the ambulance. You are always welcome to reach out to us, and we would love to show you what we can do and see how you might be able to build something like this in your community. Here's a couple of ways you can find us. And that's that.
Right. So we'll open it up to questions. Ken?
Mhm. Yes, thank you so much for sharing all of the wonderful work that you do and all of the collaborations. So yeah, we'll now invite the group. You can choose to type a question in the chat and I'll read it aloud, which may be the easiest method. Or if you'd like to ask your question yourself as participants, you can unmute your microphone and share with Robin and Heather. There was one question that came up earlier, which may have been addressed, but it might be worth discussing again. Just identifying your role in interactions and collaboration with the local police services and how that maybe tell us about how that's working, how that came to be, and just kind of dive in from there. But yes, I invite the group to type some questions in the chat.
Do you want me to take that, Robin? I think your experience early on was different than mine.
Yeah, go ahead.
Okay, so we have, I would say, pleasant relationships with police. You know, very often when we present it like this, first people say is like, oh, how do you stay safe? And we've never ever felt that we were unsafe visiting with the individuals we work with. We do have obviously contingencies in place and processes. EMS have been visiting folks in their homes and in the streets forever, and they're very used to going into environments that are strange and new. We all have a pretty good amount of grit and good gut instincts that tell us when something's up, but the people we serve, I'll be honest, love us, we love them. It's a very mutually great relationship. People are getting their needs met when they work with us, so it's been very positive. Police are seeing this as well, that wow, it doesn't always have to be confrontational. Sometimes we can mitigate conflict with police. I have dosed methadone in the jail. We have a community star table, which might be familiar to some folks on the call today, where we have our chiefs of police at that meeting, and often there is a point of view that perhaps as a nurse practitioner or as a harm reduction specialist that they haven't seen, and sometimes they consider it differently. So I've heard some of our police chiefs change at least their speaking points about the type of crime that they're seeing. They're describing it now as survival crime. They agree that homelessness is not a crime. Housing is a human right. And a lot of these things, if they were to receive mental and social assistance, they wouldn't lead to criminal behavior. We've got one agency that is actually funding some additional staff in their area because they have seen such great work coming our way. So we don't tattle to the police, but of course, as a regulated body, if there is a warrant, doesn't matter to me. But if there's a subpoena, that's different. So we have fairly positive rapport. People have asked if we would go out together to walk the beat, and the answer is absolutely not. We are very separate in that way, but we are working with the same people with the same goal as trying to keep our community safe. We're trying to keep them alive, and they're just trying to keep things safe. So from that angle, it's been fairly good. Anything to add to that, Robin?
No, I think that's just the important piece, is that the police have noticed significant impacts. While we were initially at the rooming house, we had court support there. So there was 100% attendance for bail hearings or for connection with lawyers, or there was no breaches of parole or probation. So that, I think, is significant when you're meeting people where they're at. And you know, we do owe it to the teams, right? We had, I think Jen Bates has left, but CMHA court support being there, you know, that was important relationship. And then changing the language. So often correcting language that was very stigmatizing or not recovery based. I have no problems correcting somebody who says the word addict or junkie, and correcting that to, you know, opiate use disorder or alcohol use disorder, and looking at that from a different perspective. So I think it's also that the team, Heather and the team, have been amazing at, you know, really facilitating recovery and change and how they look at it. So it looks like Eli has a question. It says, thanks for your work in this area. It sounds like you're doing amazing work with serious barriers. Do you find that you, staff, experience moral injury or burnout because they feel like they want to do more than it is possible? It's a beautiful question for you to answer, Heather. And if so, how do you respond to that? If not, what practices have you embedded to prevent vicarious trauma and moral injury? Awesome question, Eli.
It's a really great question. So I would be a liar to say it isn't hard work. We are a big team, so we now can divide and conquer. That provides us some rest periods at times. We have a very spiritual crew, which is amazing. It is not uncommon after a very busy, difficult clinic for us to, we live on the Bruce Trail. We do a lot of street outreach, and sometimes that means that we are hiking in the woods, and one of my colleagues is an absolute tree hugger, I mean, literally. And it's just so beautiful to practice in modes and methods that perhaps I wasn't trained in as a nurse practitioner or medical street medicine. We are very lucky to work with a multitude of very, very skilled mental health workers and supervisors who do take our concerns seriously. We have beautiful leadership. They hear us, they move mountains for us. So there's been very little where we've seen a need and not been able to help in some way. What else can I say about that? Yeah, we debrief every day. It's actually in the calendar to debrief every day together. Does it stick at home sometimes? Yes, but we're human. And I think all of us are in therapy. That's certainly recommended, to have our own therapists to manage this kind of lifestyle. Yeah. Does that answer that question?
Yeah, it was great, Heather.
Therapy is part of the work. Yeah.
Yeah. And I think also not being siloed, right? So being able to reach out to your partner and be like, you know what, I noticed you seem off today. Are you okay? So one thing that I've always learned is this idea of check in and check out with the people around you. And so that's really a model that I've developed in terms of making sure that, you know, when I'm aware that Heather has had, you know, a significant challenge or a fatality or something, that we reach out to each other and make sure that our team is safe.
And to answer your follow-up question there, Eli, yes. So because we work with frontline EMS, we are able to access the same resources for occupational stress injury, which includes a psychologist very within, I think, 48 hours. I haven't accessed that service myself, but I know my partners have. So there's a lot of work being done in the background for occupational stress injury, which I don't think has probably made its way to like nursing land. I don't know if people are here from that land. But because we are working with first responders, there's a sort of a different amount of access we have, which is great. Very, very thankful for it. Anything else?
Right.
So now we have a bit more time. I also get to ask a question, I think. But yes, we still encourage the group to type your questions away. So I know a lot of working with vulnerable populations really is built, and as mentioned, you mentioned it a few times, on building that trusting relationship and establishing trust. And I would love to hear an example of how that trust was built. Because I know it's unique and different each time. But to dig more into, say, what does that look like in your perspective would be helpful to hear.
Do you want me to go with that, Robin?
Yeah, sure. If you want.
Okay. I think the example of socks might seem really frivolous to some individuals, but always having extra pairs of socks in my backpack is a great start, because people may see me as the addiction specialist, and that's kind of intimidating, or a power imbalance. But when they know I've got candy and gum and socks in my backpack, and if that's all they want to dip the toe in, as they say, and then maybe next time they'll ask one more question, they'll want me to see an injection abscess, and they'll receive treatment for that, and they'll recognize that I didn't judge them. I didn't tell them to stop using. I just suggested perhaps here's some cleaner options for you if you're going to continue to use. And then next time they might inquire about what these other people are doing here, and then they might be interested in the different options available. At no point am I telling them what to do. We dress very street. We don't work with the police. There's a lot of different ways. Often it's the very small gestures of kindness and just humanity that is surprisingly and saddeningly very refreshing to this vulnerable group. So I'll go with socks every day.
Yeah, for me, it was building the understanding that we weren't any better than them. So choosing language that was more fitting within the group, and being okay to show them things. Like I've been known to sit down and show somebody how to pack a crack pipe. And food is always a key into people's hearts, and a lot of people are food deprived right now and food insecurities. So if it means going door to door, we went door to door for an entire week with hot chocolate and flyers about SOS Market and information of, and just handing that out just to get the word around, to start the markets off, that to understand that we're not out there to judge or harm.
That is those are wonderful examples. Thank you so much for sharing, and thank you so much, not just for those answers and for this Q&A, but for all of the presentation, the collaboration, and the work that you do. So now that we are coming close to the end of our session, allow me to do a bit of a closing. So for all of you who are with us, please join me in thanking our speakers for their great presentation and sharing their knowledge with us. You may be able to see a little reaction bar on your Zoom button. You can send some confetti or some hearts or some applause. Please take a few moments to complete the evaluation of this session. As a reminder, this is session A3. So here, let me throw that in the chat for you. So that is your link to your evaluation. So the first thing is name of the session. You could say A3 Bright Shores, and our data analyzers will take it from there. Thank you again for your participation, for your questions, and just some conference logistics. We'll now be taking a 60-minute lunch break to recharge. We encourage you as conference attendees to connect with fellow participants, view the poster presentations, and check out the exhibitor booths. So another reminder is that we have a wonderful, some wonderful networking sessions, and there's also a pre-recorded mindfulness session that you can find in the conference platform. All that being said, enjoy your lunch until 1 p.m. and please join us back and the plenary session for our day one keynote panel highlighting crisis response services and models across Ontario. Thanks again, everyone. Thank you, Heather. Thank you, Robin. Have a wonderful day.
Bye-bye. Take care.